small topic. Next is this counseling. Am I audible? Yes. Okay, so counseling, we have a lots of topics in counseling, but mostly the stations are a bit same. Counseling, what we need to do is in all the station mostly need to take a bit of history regarding past medical history and the personal history, and then you will counsel the patient whatever positive finding you'll get. So past medical, personal, and then whatever positive finding you will just do the management. You will counsel the patient for that. The thing is, we are not supposed to order the patient for anything. Don't say don't drink alcohol, don't smoke, don't follow this kind of diet. That is accusing the patient. What you need to do is you just need to give the patient options. Give options to the patient. Don't force the patient. Try to convince them and give them option. For example, if you want to tell the patient something about the smoking, so tell the patient like we have a lot of option for the smoking cessation. If you want to consider, I can tell you. It's like we are asking the patient if he wants to quit smoking. Don't force the patient. So whatever wording that you will use in this kind of in counseling station, make sure it should be giving offers to the patient. Like we have this option, we have this option. Which one you want to know about, and if you want to know about it or not. It's like do not force the patient. Please, please, please do not force the patient in counseling stations. That's the thing. So please do not patient in counseling station. That is the main thing that you have to consider. Just a second. So in counseling, give options to the patient, don't force. So let's read the first question that we have. Your afternoon GP patient is 55, came to the follow-up. Patient has diabetes mellitus and he has been admitted to the hospital due to cellulitis 4 weeks ago and he was treated with antibiotics. During the admission, patient was newly diagnosed with hypertension. On discharge, he was prescribed with some medication. Talk to the patient, take history, check his blood pressure and discuss the further plan of management. Yeah. So what happened is he was admitted in the last time because of cellulitis, and that time he was diagnosed with hypertension. This is what happened. So in this case, what we are supposed to do is we need to take history and check his blood pressure and discuss the plan of management. All these stations, the first thing that we should have in our mind is patient safety. Just ask about how you're feeling now, because you know from the question itself that patient had cellulitis. So ask how are you feeling now, everything is fine or not, if there is any problem or not. Yeah. And then ask about the medication, like are you taking medication regularly or not, which medication, and check the compliance if you're taking it regularly or not. Actually in this case, the patient was prescribed one medication which is ACE inhibitors. He was prescribed, but he will tell you, doctor, I'm not taking it. You're like, why, what's the problem? Why are you not taking it? He's like, doctor, actually I had a very bad cough and that is why I'm not taking it. I took it for some time, maybe for a week or something, but the cough was really bad. I was unable to sleep even. And all of us, we know there is one side effect of ACE inhibitor, which is cough, dry cough. So that is the station is all about. So what you are supposed to do in this case, ask some question related to the present condition of the patient, if patient is fine or not, and make sure if patient is taking the medication or not properly. So actually patient is not taking the medication properly. So if he's not taking antihypertensive medication, what can happen to the patient? Maybe the patient blood pressure was high throughout this 4 weeks because he didn't take medication. So you can ask some questions which are the question for hypertension. So you can ask about if you had any high blood pressure symptoms, for example, like blurring of vision or any headache. So all these things you can ask. So what you can do is you can ask the symptoms that is due to the non-compliance of this antihypertensive medication. Yeah, so that's the thing. And then explore about diabetes, because it's already mentioned in the question, patient is diabetic. So just ask a bit about the diabetes as well, like explore diabetes. For how long you have diabetes? Maybe for example, patient said 5 years. So are you taking any medication for that? No, doctor, I'm managing it with my diet. All right. So do you have any symptom like polydipsia, polyphagia? I mean, drinking enough, I mean, more water, going to the loo more often? No, no, doctor. Do you have any complication of diabetes, like any eye problem or any foot problem? No, doctor. What else we can ask? Do you go to your GP regularly? So maybe yes or maybe no. So are you going for your annual review? Yes, doctor. No, doctor. Whatsoever. The thing is, explore the things. Whatever you have the finding, explore it. So any patient, any question actually in the counseling, you need to take a bit of history in the beginning, and then we manage the patient. We counsel the patient. So in this, first of all, review patient if patient is fine or not. That's the first thing. Ask about the medication if he's taking or not. So definitely he's not taking. Yeah. Ask the reason and ask any symptom that can arise because of high blood pressure, like headache and all. Yeah, and then explore diabetes. After that, you have to take past medical history. Yeah, after that, we will take past medical history. And past medical history, what question we ask? As we know, like all these questions we ask past medical history, as having any past medical condition, if he's taking any medication, allergy, hospitalization, surgery, family history, all these questions. It's like, I would say, just mug up these questions, and in counseling, most of the counseling station, you need to ask these things only. And same, you need to ask now personal history. That's it. Smoking, alcohol, diet, exercise, if it is good or it's not good. And check the blood pressure. Usually the examiner will tell you the blood pressure. Here you don't have to check the blood pressure. Examiner will give you which is high, 170 by 100, because patient is not taking medication. So definitely the blood pressure is going to be high. Yeah. And what's the management? You know, cough is one of the side effects of ACE inhibitor. Change it to ARBs, angiotensin receptor blockers. That is losartan or telmisartan. As simple as that. It is very, very, very simple question. Yeah. So take a bit of history about past medical and personal history and the management, change the drug, that's it. And after that, you will mention about all the lifestyle advices, whatever it was positive. If the diet is not good, advice about diet. If smoking, if patient is a smoker, advice about that. If patient is drinking alcohol, advice about that. If he's not involved in physical exercise, advice about that. But again, I'm telling you, do not force the patient for anything. You just give them option. What you're supposed to do is give them a menu card. Like when you are going to a hotel, the chef there, they are not forcing on you that you have to eat this. No, they give you a menu card. Yeah, if you want to eat, you can select. So same here. First, you have to convince them. Give them a menu card. We have these options. Which one you want to consider? If you want to consider, it's not like we are not forcing. We are just giving options to you. So convince the patient. Don't force them, and give them options. Yeah. So your wording should be really nice. It should not be like we are forcing something on patient. Yeah, don't be bossy. It's a genuine talk between two person, like you and the patient, a genuine talk where you are telling like these can be the things. If you will do in your life, will be good. If you want to consider, I can tell you these things. If you want to consider, I'm just asking you. I'm just giving you options. Not, please don't force the patient. This is all about counseling. And there are some side effects of ARBs. If patient asks, I mean, doctor, you are changing my medication. Is there any side effect of ARBs? Yes, dizziness, nausea, vomiting, diarrhea, and high potassium can be one of the side effects. Yeah, so these things. Recently, they started changing the station a bit, because we know, like, if the age of the patient is less than 55 or more than 55, the drug that we give, I mean, antihypertensive is different. If it is less than 55, what drug we give? We give ACE inhibitor. Yeah, and later on we can add calcium channel blocker. If still it is high, the blood pressure. But if the patient is more than 55, then there is some change. We start with the calcium channel blocker, and then we can add ACE inhibitor. I know the Afro-Caribbean, that is a bit like exceptions are there. Yeah, so that's the thing. So sometime in this station, patient is not taking ACE inhibitor. Patient is taking amlodipine, which is a calcium channel blocker. And the side effects, one of the side effects of calcium channel blocker is the leg swelling. So you may have that station. So there are two kind of scenario in this. One is patient is taking ACE inhibitor and he developed cough. So what you will do, you will stop ACE inhibitor and you will start the patient on ARBs. The second scenario, the same stuff, the same station, patient is taking calcium channel blocker and patient develop leg swelling. So what you will do, stop calcium channel blocker and we can add we can just give him amlodip, this AC inhibitors. Yeah, ramipril and anything we can give. Yeah, so that's a bit of thing they have been changing. All right, but usually they give this cough one, but they asked actually this leg swelling also maybe once or twice. Station is saying just slightest difference. Second, we have its epilepsy one. Your actual medicine patient is 27, came to the hospital with a follow-up, and the name of this patient is Sarjeet. His name is Sarjeet Singh. He was admitted 4 weeks ago and having fits. Diagnosis of epilepsy was made and patient was discharged in medication. Yeah, talk to the patient and take a relevant history. And discharge somebody inside the cubicle. So what happens is when patient have the fit, the first fit we don't say it is epilepsy. Yeah, we make a diagnosis of epilepsy when it is repeated fits. But in the question it's mentioned patient was diagnosed with epilepsy, so we are not concerned about that. And he was discharged on some medication. So what we are supposed to do, we need to talk to the patient, and there's discharge summary inside the cubicle. Yeah. So when you go inside, actually the discharge summary it is written. Patient was prescribed sodium valproate. It's written in the question that patient was prescribed sodium valproate BD. Sodium valproate 300 mg BD. Sodium valproate BD. Yeah. So what you will do now, you will check the same stuff as we did in the previous station. The patient's condition, present condition, how you are, is everything okay? Do you had any other attack of epilepsy and all? And ask if you're taking medication or not. And if you're taking it, are you taking it regularly or not? As we did in the previous station, all this station you need to do the same way. But this patient is saying, actually, I had 2 attacks. After I started taking the medication, I had 2 attacks, doctor. Okay, so you had 2 attacks. So is there any change in the kind of attacks that you had as compared to before? So he's like, no, doctor, it's almost the same, but I had 2 attacks. So I stopped taking the medication. I was taking it regularly. I was taking it once a day. And then I started having these fits. So I stopped it. And you're like, you said once a day, but you are prescribed twice a day. So that is the one mistake that patient was doing. So that was the one reason that why the patient was having fits despite he was taking the medication on time. He misunderstood maybe in the last time that it is BD 2 times a day, but he was taking once a day. So that was the thing. And he stopped taking medication and he has like a couple of fits. Yeah. So that is the thing. So what we have to do is any other epileptic attack if patient has, so as we know in this patient had a couple of attacks. So you can ask maybe like you stop taking medication. So maybe it is because of side effects of medication. So you can ask, did you experience any side effect of the medication? Patient is like, no doctor, I didn't experience any side effect, but it's like just I don't want to take it because it is not helping because I had a fit. Yeah, so we know the cause of it is he was not taking it as prescribed. We prescribed BD, but he was taking OD once a day. Yeah, so you can explore those epileptic attacks. So patient is saying, those doctor, these epileptic attacks are similar to those which I experienced previously. Yeah, and you can ask one question, like you had these 2 fits, what were you doing that time? So patient is giving the history, doctor. Actually, at that time, I was at my friend's place. We were doing party. So now you will get a lot of triggers which can lead to epilepsy attacks. So what are the triggers of epilepsy attack? Let's see. See, all these are the triggers factors. All these are the trigger factors. Lots of trigger factors you have. Yeah, all the trigger factors. For example, patient is saying, doctor, I had this problem. I had these attacks when I was at my friend's place. We were doing party. So in the party, what are the factors that you can get? In the party, there is a flashing light, always a chance. Loud music, yes. Recreational drug, maybe, may not be. Skipping meals, yes. Maybe they are too much enjoying and they might skip the meals. Lack of sleep, yes. Dehydration, yes. If they are drinking alcohol, maybe they are dehydrated. And stress. See, all these are the risk factors of getting an epileptic attack. So that is why we need to ask, like, what were you doing when you had this epilepsy attack? And he was telling me that I was at my friend's place. So you can try to find out these risk factors. That is very, very important. So you may get some of the factors positive. So don't think that you will get everything everything positive, but there are chances that you will get some of these positive, and then you can advise about them later on in the management. And there are some general advices that you can give it to the patient. General advice like, see, a patient can have epilepsy attack anytime. So tell the patient, use guards on radiator and heater, because after having an attack, patient can fall down on the radiator. So it's always better if there are guard on them. Cover any sharp furniture edges. So there should not be any sharp edges of the furniture. Take shower instead of bath. Take shower instead of bath. Why? What's the use? What's the fun in doing that? The thing is, if you take shower, there are, I mean, if you have an attack, so at least you will not drown in water. If you are sitting in a bathtub and you had an epilepsy attack, there are chances that you may drown in water. Yeah, so it's better to take shower instead of bath. And wear epilepsy bracelets. They have epilepsy bracelet, like we discussed in the morning time. We have a steroid card for like in GCS station if you're prescribing steroid for a long time. So same here, like if patient is diagnosed case of epilepsy, we usually give this epilepsy bracelet. Yeah, so there's some general advice that you can give. And always anyone can ask what are side effects of the drugs, maybe this, what do you say, sodium valproate. So you can mention about these things. These are the side effects of sodium valproate. If it asks, you can mention it: nausea, gastric irritation, diarrhea, weight gain, increased ammonia, and hair loss. So these are side effects of this sodium valproate. If patient is asking, you can mention about it. Yeah, so that's the station all about epilepsy. Clostridium difficile associated diarrhea, CD80. You are in medicine, patient is 75, present in the hospital 10 days ago. Patient was diagnosed with pneumonia and was treated with antibiotics. Patient developed diarrhea 2 days ago, but before being discharged, stool sample was sent and it shows CD80. Patient was moved to another ward with the patient with similar condition. He's now receiving IV fluids and antibiotics. So talk to the son and address his concern. So that's the question here. Yeah. All right. So what we will do in this, explore the present situation. Ask, how's the father now? That's the thing. So first of all, you know why the patient has diarrhea. CD80 Clostridium difficile. Patient was already taking the antibiotics for pneumonia. Yeah. So how we start the station? First is patient safety. Ask, how's the father now? Any problem, any cough, shortness of breath, and all those things. Rule out the pneumonia. Pneumonia is okay at the moment. Yeah. Now the presenting complaint is diarrhea. So he's like concerned why the diarrhea happened. So why diarrhea happened? This is because of the antibiotic usage. So he was like, oh, it happened because of antibiotic. It means you gave the wrong antibiotics to my father. No, you need to explain this is actually one of the side effects of the antibiotics. It can happen. Your father had pneumonia, so we had to give antibiotics. So sometimes what can happen, it can alter the flora of our bowel. And what can happen, patient can present with the diarrhea. This is what happened in your father's case. It's one of the side effects and it can happen with anyone. So he's like, okay, so what we do actually, the patient is a diagnosed case of CD80, Clostridium difficile associated diarrhea. We usually shift them in a separate room or separate ward. And he's a bit concerned. Why separate room? Why? What's the problem? So then you have to explain, like, if we will keep your father here, the thing is that it's the chances that it might spread to other patients as well. And maybe the father immunity is also not good, so he can also get another infection. So this is how you can convince that patient. Yeah. And the treatment, as we know, we know that isolate the patient. We need to isolate the patient. We need to routine blood investigation. We do colonoscopy. Why we do colonoscopy? We just want to find out if there's any problem or not. Patient altered flora, so we have to check by doing colonoscopy and X-ray and CT scan. We can mention, and the management is using the IV fluids. That's the first thing, and antibiotics. So when you mention about antibiotics, that we have to give antibiotics, patient, the son, he's like, oh, come on, doctor, you told me that you gave enough antibiotics, and that's one of the side effects, that my patient developed CD80 now, Clostridium difficile, and now you are saying that treatment is again antibiotics. That's not good. That's not the right thing that you're doing. Then you need to explain it to the patient that we have some stronger painkiller and we have to give to treat this CD80. So the treatment usually we give it is vancomycin and metronidazole, and it's a long course, roughly 2 weeks course. Yeah, and we can give some protein and mineral supplements. Yeah, and complication of CD80. If someone asks, you can mention about it, can lead to operation. That is why we did all those colonoscopy and CT and all. Some general advices we can give, like when you are going to meet your father, wash your hand with soap and water. Visitor to wear disposable glove and gowns and don't share towels. And one very important thing that we have kept in red: alcohol and gels are not effective against CDAD. So whenever any doctor, they're going to meet the patient, they're going to see the patient inside, they usually glove and gown. Yeah, and that's it. And don't share towels. So some general advice. MRSA, methicillin resistant Staphylococcus aureus. So it's again a very important station. They are asking, you are in a respiratory department, patient. Just a second. Just a second. There's some problem with PPTs. I'll just bring it up. Propanol, simvastatin, clopidogrel, and ramipril. These are the medication which we have prescribed to our patient. Please talk to the patient, discuss about lifestyle modification and address his concern. So they want us to talk about lifestyle. But again, what you need to do in the beginning when you assess his current situation. Yeah, that is very important. How we feeling now? Any chest pain, any chest tightness, any shortness of breath, any sweating, all those things, just to make sure your patient is absolutely fine at the moment. Patient safety first thing. Again, after that we'll look for other things. Then take again a bit of past medical history and personal history. Again, any medical history, any medication if he's taking, any allergy, hospitalization, surgery, any smoking, alcohol, lifestyle, diet, whatever positive you will get, and then you will comment it on the management part, advise accordingly. That's it. So let's discuss it in a bit detail. Like if you have a smoking, for example, if patient is saying yes, I mean, we have to use this thing actually in most of the stations, the same stuff. So let's discuss it in detail, a bit more detail here in this station, and it will be helpful for you in all the stations. So smoking, we have a lots of options. So tell the patient, I mean, if you want to consider quitting about smoking, we have lots of options for you. We have option like there are some medical, non-medical options. Yeah. So there is a screening that we have, that is smoking cessation clinic. So we can refer you to smoking cessation clinic. So you will come in contact with a lot of patients, those who are they're used to smoke, but now they have quit smoking. So that will be really helpful because they can share their experiences with you, that how did they quit smoking. So it will be really helpful. If you want to consider, we can refer you to those clinics. And there are some other options that we have for you. It's NRT. NRT is a nicotine replacement therapy. So we can offer you this nicotine replacement therapy as well. We can give you some patches and some chewing gum that will be helpful in doing this smoking cessation. Yeah. And if you want to consider, we can give you some a medical option as well. We have this medication that is varenicline and bupropion. Yeah. It comes as the name of Chimpax and Zimban. Actually, we have written in the notes, you can see, but it's fine. You don't have to name the brand name or something. But these are the medical options that we can give. So this is how you can tackle the smoking part. Alcohol, we have these options like medical and non-medical. Alcohol Anonymous, again, it's the same group, like this anonymous group. And the people, those who are used to smoke, they will share experiences with you and how they quit smoke, how they quit alcohol, and how they cut it down. That is, in terms of smoking, you have to say, cut it down and eventually stop. In alcohol, we have to say cut it down. See, it's make sure when you say about alcohol, there's a very few occasion we have to say stop drinking alcohol. If patient is having some problem due to alcohol, you will say stop alcohol. Otherwise, you will say cut down your alcohol. So that's a slight difference that you have to make sure. Yeah, whether it's cut down or stop. So smoking is we stop. Alcohol is usually cut down. So non-medical option, Alcohol Anonymous, one-to-one or CBT. CBT is like cognitive behavioral therapy. We can refer you to psychiatrist or psychologist so they can have some sessions. Family therapy, yes. I mean, if someone in the family is getting annoyed and he can help you actually. So this is the stop. Alcohol diary. Actually, in these kind of station, we can also mention that we can you can have an alcohol diary. So in that we will keep a record like how much you used to drink and now how much you have cut it down. So we will make a goal like we will reach to that particular goal at this particular time. So we will not be doing all of a sudden. So slowly we will cut down your alcohol habits. So this is how you can explain about alcohol diary. And there are some medical options as well. For example, acamprosate, and that is anti-craving. Naltrexone, it's a pure antagonist. Disulfiram, it's a deterrent that you will be having very unpleasant feeling. And chloride oxide is for withdrawal symptoms. Yeah, diet, you can say some diet is like if a patient is not having a good diet, you can say high fiber diet, control portion size, like 5 portions per day, and please include fruits and vegetables in your diet, and 2 portions of oily fish per week. It's not 2 to 4, I would say 2 portions of oily fish, and you can refer the patient to the dietitian. The people refer you to the dietitian, and they can tell you much better. And then physical exercise, this is how we can explain. It's like 30 minutes per day exercise. It's usually like 30-minute session maybe, or you can do like 2 sessions of 15 minutes and maybe 3 sessions for 10 minutes each, and try to use more of public transport, and instead of using lifts you can use you can climb stairs. That's more than enough. Sometimes patients they have like lots of things to say, doctor, I don't get time to go to the gym and something. So you don't have to go to gym. You can include this physical activity in your daily routine. You can just walk simply for 30 minutes, maybe 1 session or 15 minute 2 session, or 10 minutes 3 session. That is more than enough. So no one is telling you to go to gym or something. Yeah, and use public transport and climb stairs. This is what you can mention. Yeah. And sometimes these patients they are having some question when I can drive. So if they are driving, so it is like 4 weeks after a heart attack, and if they are driving heavy vehicle, it's roughly 6 weeks. And they're asking like when we can do sex. So you can say it's roughly 4 to 6 weeks after MI, or if you can do it like without getting breathless, so you can do it. Yeah. So there's some questions sometimes they ask. Vascular dementia lifestyle. Recently, they started asking this question. So it is like you're after in medicine, Kathy, 55-year-old diagnosed with psoriasis, and she's using skin emollients, and her psoriasis is well controlled, and the BMI of the patient is 32. Talk to the patient and address her concern. So what they want is, I mean, this question is a bit like awkward. Question says psoriasis, and patient is taking the skin emollients, and it's written that psoriasis is under control. BMI is high. When you enter into the station, when you ask the first question, how can I help you? Patient is saying, doctor, what is dementia? And you are like a bit scared, you are confused. Dementia, what do you mean by dementia? Why the patient is asking about dementia? So once you will elaborate a bit more about dementia, like why you're asking, then patient will tell doctor, actually I'm a bit concerned about vascular dementia because my friend, my family member, my sister, she has got vascular dementia. I'm a bit worried that is there any chance that I will also get vascular dementia? So that is the main concern. So what you need to do is you need to take again past medical history and personal history. First you ask a bit of my days, are you able to concentrate on your work? All those things you can ask, and then you have to take past medical history and personal history. Past medical history again, any medical condition, or yes, patient has medical condition that is psoriasis, yeah, and any other medical condition, no. Are you using any medication, allergies, surgery, hospitalization, any family history? Yes, family history. She is giving that dementia, vascular dementia. That's why she is worried. Yeah. After that is the personal history. See, the personal history is very important. Vascular dementia. The main cause is stroke, I would say. If a patient had stroke, yeah, they can lead to vascular dementia. So you need to take a very good personal history regarding smoking, regarding alcohol, and the diet and the physical exercise. And you know, there's one thing that's given in the question itself. The BMI is 32. That is again one of the risk factor of this vascular dementia. Yeah, so all those things, you need to take a very good history. You need to take a very good personal history. You need to take a very good past medical history. And after that, verbalize about the examination. We'll be doing the examination. We will be doing some investigations. So in this, what we have to do is usually we do a Q scoring. Q score. This score is actually tells us that what are the chances of our patient getting a stroke in the recent future, in next 10 years. So this scoring is really helpful. See, the thing is, this scoring we can't do just like sitting. We need a laptop or we need something like. So we can mention it to the patient that we'll be doing some investigation and we'll check out your Q scoring. Yeah. And on the basis of that, we will see what are the chances of you getting some stroke in the future, because that is one of the reasons of getting vascular dementia. So now, how will you convince this patient? See, in vascular dementia, there are some modifiable causes. There are non-modifiable causes. What are non-modifiable causes? The age of the patient. Can you modify it? Definitely not. You can't do anything with the age of the patient. Patient has a family history of vascular dementia. So we can't do anything for that as well. Now talk about modifiable causes that we can do something. So modifiable causes are smoking, modifiable causes are alcohol, the diet, and the physical exercises. So all these things, they are the modifiable causes, and then you will talk about all these modifiable causes. Then use this BMI 32 in also in your consultation, that your BMI is high. That is again one of the reasons. So mention about the treatment of that BMI, like how you can tackle it. Yeah. And then the next one is osteoporosis. So the psoriasis and the vascular dementia, and before that the post-MI lifestyle. They're same kind of station. There's nothing that I mean, it's just totally lifestyle. Osteoporosis, this is again totally lifestyle station. Patient 62, patient had a wrist fracture 3 months ago and she was managed. And the DEXA scan done which shows osteoporosis. And she came for the result. Talk to her for the result. So again, take history, past medical and personal history, and she's here for the result. You can ask some questions about the wrist fracture as well. I mean, if the wrist is fine or not, any pain, are you able to move it properly, are you able to do your work or not, just for the patient safety in the beginning. And then what we are supposed to do in this patient is you need to disclose osteoporosis. Yeah, disclose osteoporosis, that we have done DEXA scan which shows osteoporosis means weak bone. So what we are supposed to do is assess current situation, then ask about past medical history and personal history the same way. Past medical history, any medical condition, any medication. If you're taking medication, you can ask steroid maybe, yeah. And you can ask about any surgery. Maybe patient is a female patient, might give you history of hysterectomy. So that is again a risk factor, risk factor of getting the osteoporosis, yeah. And then we'll ask about personal history. Personal history means any smoking, alcohol, they are the risk factor. Ask about diet and ask about whether he or she is including the milk and milk products in the diet or not, because that is very, very important. If not, if they are not including, again, a risk factor of getting a weak bone and getting fracture. So all those things like personal history, there is nothing that you have to worry. So advise accordingly. Whatever positive thing you will get, you will advise the patient. Calcium supplements and bisphosphonates we can offer as a treatment plan. Yeah. So this is actually the risk factor if you want to consider what are the risk factors. So female sex, this is a risk factor of getting osteoporosis. Menopause, that's why menopause? Because the patient has hysterectomy actually, so patient will be having early menopause. That can be the risk factor of osteoporosis, hyperparathyroidism, steroid, and diet. Yeah. So all those things are very, very, very important. Next station is a stroke assessment. Again, it is a very easy station, fast as we did in TIA. So remember this fast. Facial droop, arm weakness, slurred speech, time. Time to call or time lost is brain lost. Yeah. So the question in this says you are actually in GP, patient is 60-year-old present in the clinic. He has some concern about stroke. Patient is concerned about stroke. The nurse colleague checked the vitals and blood pressure was found 150/100. The vitals are 150/100. Talk to the patient and address the concern. So patient is concerned about the stroke. So you can ask why you are concerned. So patient is telling why I'm concerned is because my father died of stroke and my brother recently had a stroke. That's why I'm concerned if I'll get a stroke or not. So again, what you can do, as we did in previous station, ask some symptom of stroke or TIA. What you will ask: facial droop. Any facial weakness? No. Any arm weakness? No. Any slurred speech? No. All right. Then take past medical history and personal history. Yeah. Any medical condition, medication, surgery, hospitalization, allergy, everything, smoking, alcohol, diet, physical exercise, the same stuff. And now what's the management? See, one thing is, if you've seen the question, it is mentioned it is mentioned in the question, patient blood pressure is 150/100, which is high. Yeah, but when you are taking this past medical history, patient is not telling you that I'm having high blood pressure. So maybe it is the first reading which was high. Yeah. So mention it to the patient that we examined you and we found the blood pressure was a bit high, but patient is saying I don't have any blood pressure. So don't worry. What we can do is we will keep on checking your blood pressure. Yeah, that is what we can say. We are not going to offer medication in the first attempt only. Like if patient is having one reading of high blood pressure, that doesn't mean we are going to give him medication. We will say we will monitor your blood pressure. That's it. We'll monitor your blood pressure. That's it. And what else we will say? Now the management comes. Management is actually again the same way. There are some modifiable things, there are some non-modifiable things. What are what do you say? What are non-modifiable? First of all, being a male is a risk factor of getting a stroke. Second is you had a family history. Your age, so patient more than 55 more prone to have. So that is a non-modifiable factor we can't do. Being a male, again, the second risk factor that we can't do anything. And a family history, the third thing. So all these three things you can't do anything. A patient will develop stroke, you can't do anything. That is a non-modifiable factor. But there are some modifiable factors. For example, smoking, alcohol, diet, physical exercise. Whatever positive you will get, you will counsel the patient accordingly. Yeah. And once you have done all these things, last 1-2 minutes, make sure you offer this mini aspirin to the patient and say we will be doing some further investigations. All the routine blood investigation. That's it. And before you finish the station, make sure you mention about this thing. Sorry. You mentioned about this warning sign: facial drooping, arm weakness, slurred speech. It's time to fall. Yeah. So that's the thing. Please don't miss it. Very, very, very important. Obesity counseling. This again a lifestyle station. There's nothing. I mean, see, in counseling station, there's nothing to teach. Just practice it. Practice in this way that you will not sound like you are forcing something on the patient. It should be like that you are giving the option to the patient. That's the thing. Obesity again. Let's read the question. Patient is 52 and is an overweight patient. Talk to the patient. Address the concern. So again. Obesity can have a lots of causes. It can be like hypothyroidism, as you know, and the patient is using long-term steroid like Cushing syndrome. That can be the cause. Diet, yeah, if they're eating too much of the stuff like the stuff which is enriched in, very sweet stuff if they are eating. So, and eating like chips, burgers, and all those. Stuff like fried food. So that is again a reason of obesity. Physical activity. If they are not doing any physical activity, very much like just on the bed, on the chair, just all the time. And family history of obesity. If there is a family history of obesity, there are chances the patient will be obese. So again, you will take past medical history, patient is having any past medical condition or not, because we need to rule out other things. Patient is young and 52, so you have to rule out PCOS, other things, yeah. And if patient is using long-term steroid, hypothyroidism, all those stuff, yeah. And personal history, you'll ask about smoking, alcohol, and make sure diet is very important, physical exercise. So these things you need to ask. And the BMI, and the examiner is giving the BMI, which is 40. So we know it is high, 40. It's too high. The normal is between 18.5 to 24.9. If it is more, it is more. But it is 40. It is morbid obesity. It is morbid obesity. Usually for adults, the BMI 18.5 to 24.9 means you are healthy weight. Overweight is 25 to 20.9. It is overweight. If it is 30 and 30.9, it is obese. But if it is 40, it is severely obese. Actually, it's morbid obesity. It's very, very high. So in this station, what's the treatment is lifestyle changes. Lifestyle changes is the treatment. That is what you need to mention. Yeah. Like if patient is giving you very bad diet, so counsel the patient for the diet. If they are giving you like very, very bad physical exercise, so we mentioned about the physical exercise that you should involve into physical exercises. That is a part of treatment. But see, in this case, the way you will disclose the diagnosis, that is a bit tricky. Don't say you are fat. Don't say you are obese. Say in a nice way. Say that your weight according to your height is high. That is a subtle way to say that you are obese. Don't say you are fat, you are obese. So patient might take it in the wrong way. Say it in a very nice way. And the treatment is only lifestyle changes. If patient is asking about medication, we can mention that is orlistat. What is the function of orlistat? Actually, doesn't it stops the fat absorption, it decreases the absorption of fat. But usually we don't offer medication. We just give lifestyle advices as a main part of treatment. We give lifestyle advices as a main part of treatment. We don't give any medication or these kind of stuff. But we can give orlistat with lifestyle changes. You got my point? First treatment is lifestyle changes. Second is lifestyle changes maybe with orlistat. That is the thing. If taken correctly, this medication works by reducing the fat you absorb in the digestion. So don't offer medication. The first thing first is simply lifestyle changes. But if patient is asking any medication you have, yes, we have medication, but that medication will not work if you will not make necessary changes in your lifestyle. Yeah, and the side effect is, side effect of this orlistat will be, the fat you will get in the stools. The patient will pass fat in the stools. So maybe the fat things you will get, maybe it's on the clothes or something. Underpants may stain with the fat content because the patient will be having, patient will not be able to absorb fat because that's the function of orlistat. If patient asks about surgery, you can mention about the surgery as well. Gastric banding, we can do bypass or sleeve gastrectomy. Don't worry, this patient will not go to the back. But the main should make sure you give lifestyle advice. The main station. This is the station about lifestyle. All the stations are lifestyle actually in the end. Statin. Let's read the question of statin. Patient is 55, came for a health checkup. All the blood tests, blood sugar, LFT, UNEs came back normal. Only the cholesterol that was found high, and the Q-risk score is 14. That is the Q-risk score we were talking about. The Q-risk score I was talking about in vascular dementia station. That is what we check. It is 14. So what does it mean? That the chances for this patient, the chances of getting stroke in next 10 years is 14%. This is the function of Q-risk score. That is why we did Q-risk in the previous station, in the vascular dementia patient, because these patients will get to know if there are chances of getting this stroke or not. So in this, what is mentioned, cholesterol was high, and the Q-risk score is 14. She should be on statin. Talk to the patient, discuss the plan of management. So again, this is again a lifestyle station, but one difference is there. It's mentioned patient should be on statin. In all the station, we try not to give the medication. First, we give lifestyle advices, and then we start the patient medication. The slight difference in this station. It's already mentioned in the question, patient should be on statin. So first, after you have taken a brief history, the first thing that you will do, you tell the patient you will start your treatment, the statin. Yeah. So mention about the statin first, and then you can go for the lifestyle advices. That's the slight difference. So again, take past medical history and personal history and give lifestyle advices. But before you give lifestyle advices, please do mention statin, that we are going to start you on statin. Yeah. And then whatever time you're left with, you just give him or her lifestyle advices. And the patient can ask you what are the side effects of this thing. The side effects of statins are increased blood sugar, increased blood pressure, constipation, diarrhea, joint pain, muscle pain. That's it. Next is diabetic retinopathy. Again, this is same kind of station, lifestyle station. GP patient is 48, came to the clinic with a new problem. Oh my, new problem. What's the problem? Let's see. Patient is a diagnosed case of non-insulin dependent diabetes mellitus, which is controlled on diet. Talk to the patient and discuss the plan of management. Please do not examine the patient. So sometimes they just mention do not examine the patient. Yeah. So when you get inside the cubicle, actually the patient gives you a letter. Like, doctor, actually I went to my optician and he gave me this letter. Let's read the letter. We examined the eyes of 48-year-old gentleman. Patient was diagnosed with diabetes. Patient visual acuity is normal. On examination, there is early background changes in the retina. Carry this letter when you see to your GP. Follow-up is required. This is the scenario. So you have the scenario, and when you go inside, the first thing that your patient will do, patient will give you a letter where these things are mentioned, that patient is diabetic and there is a early background changes in the retina. So, all right, after that, what we will do, we will ask, first of all, why you went to optician. See, patient went to optician, and optician did the test, but then why he went to the optician? So what can be the reason? That we will try to find out. So he will say, doctor, actually, I'm a painter, and when I'm doing painting, it's difficult for me to see. I can't concentrate, and there is difficult to see fine lines. I can't see. That's why I went to optician. All right, then you go for past medical history, and you know that from the question itself, patient is diabetic. So elaborate the diabetic, for how long patient is diabetic, what he's taking for the diabetes, if he's going for GP reviews, going for annual review, if he's developed any complication of diabetes. All the question you ask for diabetes, take past medical history and personal history, and that's it, and advise accordingly. That's it. We have to do some further investigation, like we can do fluorescent angiogram. That's the thing. Nothing is there again, lifestyle station. Patient is asking these two questions. Is it reversible? Will I go blind? First of all, it's mentioned early background changes. Is it reversible? The thing is, NHS says early background changes are reversible, but when patient is in early background changes, we don't do any treatment. We just tell the patient about the lifestyle advice. We don't do any treatment if patient is in early background changes. So is it reversible? Actually, it's not reversible. Why? Because we will not treat if it is early background changes. What we do, we just do lifestyle advices. Yeah. So we can say it's not reversible, that's it. But we can stop the progression of your disease if you control it. That's okay. Will I go blind? The thing is that if you will take treatment as we are prescribing, so we can stop it. We will not get blind. Yeah, that's it. Diabetic review. There are lots of station of diabetes actually. So the same way you need to do it. So you are actually in GP surgery. Patient is 52 years old, diagnosed with type 1 diabetes, and on examination, he's on insulin, and examination was done by the nurse. He has loss of sensation and the pain below ankle bilaterally. So loss of fun sensation, loss of pain sensation below the ankle bilaterally. Urine test has been done and it shows 2 plus glucose and protein. The patient has been seen by the optician. Fundoscopy has been done and it shows dots and blots. The proliferative retinopathy. The plan is to refer the patient to ophthalmologist. His prescription was 1 month old. Talk to the patient and talk to the patient about the diabetes control and discuss the initial plan of management with the patient. Don't examine the patient. Okay, this patient is also like, what they want to say is this prescription is 1 month old. The thing is, what they want to say is the patient is not going for the follow-up and all. This is what they want to say in this case. All right. So again, the same way you will take history, past medical history and personal history, and we already know patient is diabetic, so you will elaborate the diabetes. And again, advise accordingly. Investigation, fluorescent. Patient has got same concern. Is it reversible? Will I go blind? So there's nothing there. There's same station. Both are station are same. So some slight changes you may see. Otherwise, they are same. Hypoglycemia. You are in GP patient 35 had an episode of hypoglycemia 2 weeks back. Now he came for diabetic review. His HbA1c is 61. Talk to him and address his concern. Talk to him and address his concern. So again, what you will do in this case, you again explore the diabetes, the past medical history and the personal history as we have done in the all the stations. And that's it. Advise accordingly, and diabetes bracelet. We have a diabetes bracelet as well. One thing in this station is what happened is just a second. HbA1c is 61. Usually it should not be more than 48. Yeah, I think if you see your booklets, we have put a WHO chart, so you can see what is normal, what is abnormal, because the value here they have different units, and the value we have in our countries they are different. So make sure we know the normal values for this, what is normal and what is diabetic. So HbA1c 61 is high. Patient is saying actually his name is as an Asian man. He says I love some, what do you say, some sweets. He's naming some sweets like I love rasgulla, I love jalebi, gulab jamun. Always he's giving this kind of history, and he's saying that actually what happened is I went into one of the party and I ate a lot of sweets, and what after that what I did is I took insulin. I took more dose of insulin, and then I felt a bit shaky. I felt a bit of tremor and sweating, but then I called my sister who is a nurse, and she told me it might be the low blood sugar, and I took some chocolate. I was fine. So this is a bit of a story behind this patient. This patient is actually taking the medication regularly, but he ate a lot of sweets, and because of that, he took a lot of insulin, more insulin than prescribed, and that's why he was in hypoglycemia stuff. So that's the same thing. Just see this chart. This is pretty important chart. DVLA. The thing is, the patient who is in hypoglycemia, they need to inform DVLA. The patient who is diabetic, they have to inform DVLA. Who has to inform? Who doesn't have to inform? See, if we are controlling the diabetes only on diet, so there is no need to inform DVLA. There is no need to inform DVLA. But if patient is taking sulfonylureas or glenides, then, and if they are driving bus, coach or lorry, then they have to inform DVLA. Same if they are on any diabetic tablets or incretins, they have to inform DVLA if they are driving bus, coach. But if they are on insulin, they have to inform DVLA. Doesn't matter if they are driving car or if they are driving bus. So sometimes this patient asks a question. Actually, he's on insulin, so he's asking, doctor, should I inform DVLA? Or you have to tell him that you have to inform DVLA. So he's a bit worried. He's saying, doctor, I'm a professional driver, so if I inform DVLA, I won't be able to drive. You have to tell, no, it's not the case. It's not the case. It's just for the safety, so that the DVLA will call you for frequent testing. That's why we are telling you to inform DVLA, but that doesn't mean that they will tell you to stop or something. So this is when to inform DVLA, when not to inform. So that chart will be really helpful. And we have kept this chart in your booklet, so you can see. And signs of hypoglycemia, you give as a warning sign if you feel shaky, dizzy, sweaty, hungry, irritable, moody, anxiety, nervousness, headache, you can come to the hospital. Yeah, if any of these happens, eat chocolate or sugary drink, that's it, and come to the hospital maybe. Yeah. But all the patients who are having hypoglycemia, they don't have to come to the hospital. They know, actually know who is the best doctor of a diabetic patient. They themselves, they are the best doctor. They know from their body itself, they know if the blood sugar is high or low, because they are much more experienced. The next station we have is hypoglycemic fits. So there are lots of stations of diabetes. Actually, the same stuff is there. There's nothing special. We're after in A&E. John, age 22, known case of type 1 diabetes, is on insulin, brought to the A&E by the ambulance after he was found collapsed. The vitals have been given in the question. The blood pressure is 160, the pulse rate is 105, the respiratory rate is 20, SATs are 95, and the blood sugar is 2.1. Talk to the patient, take history, convince him to get admitted, and discuss your initial plan of management with the patient. So you need to convince the patient to stay in the hospital, and patient doesn't want to stay in the hospital. So it's like you have to convince the patient. You have to show him that why you need to be in the hospital. There's nothing, it's the same as hypoglycemia station. So first, what happened is patient had a fit. So you can elaborate a bit about the fit as we discussed in the morning, like during, before, after. But this patient actually saying, I don't know what happened to me. I was just collapsed and someone brought me to the hospital. All right, so you don't have that much of history. Then again, you will elaborate the diabetes history, for how long you have diabetes and all everything, and why this patient wants to go home. He's saying, doctor, actually, it's my marriage in the next few days. I have to do a lot of shopping. That's why I have to go to the home. I have to go to home and I have to do a shopping. So let me go home. I'm feeling absolutely fine. But the question says we have to keep the patient in the hospital. Yeah. So this is how we have to convince the patient. So how will you convince, like, it's for your own health and for your safety? You said you want to go home because it's your marriage, but if you're not completely fine and if you go home, so maybe you have to come to the hospital again. I'm sure you don't want that, and we also don't want. So it's advisable if you stay in the hospital so that we can carry out all the investigation. And once you're absolutely fine, definitely we'll send you home. So this is how you can convince the patient. Yeah. So always in counseling station, always give them the option. Always give them the option. Try to talk in general. Instead of saying you should not drink alcohol, you should not smoke cigarettes, say it is advisable not to smoke, advisable not to drink. It is recommended not to drink, not to smoke. So that is, we are talking it in a bit more general terminology instead of telling it to the patient. Talking more in general. There is one more station, diabetic ketoacidosis. So that is again the same stuff. It is like patient is 25-year-old. She's brought to the hospital by the ambulance. She has been diagnosed with type 1 diabetes. She is insulin dependent. The blood has been done and the diagnosis of DKA has been made, and patient is not willing to stay in the hospital. The blood pressure is low, the pulse is high, O2 sat is 95, respiratory rate is 17, temperature is fine. Talk to the patient and address the concern. So in this case, what you need to do is just you will take a bit of history of the diabetes, for how long you have been diabetes and what you are taking for the diabetes. Everything you will elaborate. You will take a history and then patient will tell you, doctor, I want to lose weight. That's why I didn't take insulin for some time. That is the reason that patient is into this DKA. Yeah. And once you have taken the history, you will mention about the investigation stuff, and you will get a lots of investigation finding inside the cubicle, which shows it's DKA. You will be having ABG finding, and you will be having ketone positive. Everything you will get in the cubicle, which tells it's a DKA. So you will disclose it to the patient that you have DKA, and you will give the management. What's the management of DKA? Is just giving fluids to the patient. We will give you fluids, and we will keep monitoring your urine protein. Yeah, so keep monitoring the patient. She's like, okay, doctor, I'll take my insulin, and the treatment is insulin also. So I'll let me go home. I'll take my insulin, but we have to say that we have to continuously monitor you. So we cannot let you go home because it can be dangerous. So you need to convince the patient. So try to convince the patient till the end. But if patient is not getting convinced, there's a last option you have. You can scare the patient. The patient is literally giving you a hard time. No, doctor, I want to go home. I'm fine. So you can say like, if you go home, there can be some complication, which can be life-threatening. You might go into coma. You might die. So that is the thing you can use it, but it will be the last thing that you will use in the station. But you try to convince the patient in the beginning itself, like tell the patient why it is necessary to stay in the hospital, because we need to monitor you continuously. We need to monitor your blood sugar. We need to monitor your urine. We need to see your urine ketone regularly. And once we are sure, once we are able to find like there is no problem at all, then you can go home easily. Yeah, so all these things you have to mention. DKA. Treatment is fluids, and measure this ketones. We just keep on checking your urine ketone and give you insulin. That is a part of treatment. Not much. This warfarin, actually the name is derived from war. That is a Wisconsin Aluminum Research Foundation, and airing it's for coumarin. So it's actually the combination of two things, and that's why it's known as warfarin. It is very, 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 very important station, and it's a bit tricky station as well. I'll tell you why it is a bit tricky. Let's read the question first. The question is, you are active in medicine. You are active in medicine. Patient is 35 years old, presented to the hospital with the leg pain. Patient presented to the hospital with leg pain, and he was diagnosed with a deep vein thrombosis, DVT, deep vein thrombosis. And the patient was prescribed warfarin and is about to get discharged. Patient is prescribed warfarin and is about to get discharged. Talk to the patient, explain about the medication and address the patient's concern. That's the station. Yeah. Hmm. Uh, Station is easy. It's written, it's DVT, and we have given warfarin. So what you have to do is simply assess the patient's current situation. So how's the leg pain now, if you have any pain at the moment or not. You feel fine now. You will ask about the past medical condition, if there's any medical condition or any medication, allergy, hospitalization, surgery. Same with the person. This patient is having some learning disability. Whatever you will say, I mean, if you are a bit fast, he's like, what? He will not understand, I mean, very easily. So that is how he's giving a bit of tough time. It is usually not mentioned in the question that patient is having learning disability. But when you talk to the patient, you will come to know, oh, he's having learning disability. So you come to know when you start talking to the patient that whatever you are saying is not getting it right. He's not getting it right, or it takes a bit of time and he's a bit slow in understanding. So that's the thing. So you can say, like, if you want, I can explain it to someone else. I can explain someone else from your family. Yeah. What else we can say? Mm, 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 maybe I can write it for you, and if you want, I can explain it to you again. So all these things you can explain it to the patient. Yeah. And also, we are going to give you some booklets and leaflets. I'll show you what kind of booklets. In this, what you have to tell the patient that this medication to be taken at 6 p.m. with full glass of water. First of all, why at 6 p.m.? There is a particular timing, 6 o'clock, but why? The thing is, usually what happens is initially when we start the patient on warfarin, what we do in the beginning itself, what we do is we check the uh, we check blood, we check INR daily for few days, then maybe alternate day or maybe once in a week or maybe once in 2 3 weeks. This is how we go with INR. So what we do, we call the patient in the clinic, we call the patient in the warfarin clinic or GP clinic, and we take the blood sample and we send the patient home. And before we close our GP surgery, we call the patient and we usually tell them, this is the amount of drug that you need to take. You need to take 1 mg, 2 mg, 3 mg, 5 mg, 10 mg. So whatever is the case, then we will tell the patient. So that is why it's roughly 6 p.m. initially with a full glass of water. Yeah. Tell the patient, follow up with your GP regularly, regular blood tests we have to do. Yeah, that's the thing. But make sure what we need to say in this session is patients have learning disability. So make sure don't go too fast. So these are the things that you can tell it to the patient that we will give you a booklet. So there is a booklet, there is an alert card, there is a record book. So this is that's the thing. There's the first one, the first diagram that you can see. It's a booklet, and you can see the last picture, the alert card, like a debit card. That you what is you can see. So what happens is again it's like a debit card, and you can keep in your pocket. So the patient, so the if by any chance if you met with an accident or something, so what we can do, we can will be knowing that you are having this problem. I mean, you are taking warfarin for something. So we'll be a bit alert in that case. So that's why we always tell the patient to keep this alert card with you all the time. So you can offer, like, we will be giving you these things. We'll be giving you this booklet, alert card, and record book. Yeah. Hmm. Side effect of this warfarin is bleeding, nausea, vomiting. Of course, the bleeding is a side effect because anticoagulants, the bleeding is one of the important side effects. General advices. So these are some general advices that you can mention to the patient that take the medication regularly. Very important advice. and tell your pharmacist if you're going for any other medication. For example, if you develop headache and you're going to the pharmacist, it's better to tell the pharmacist that I'm taking warfarin. Why it is important? Because see, if patient is taking warfarin, and so we will be a bit cautious in giving the painkiller and all. We might not give a diclofenac or ibuprofen. We might give simple paracetamol for pain. So that's the thing. So tell the pharmacist that you are taking this medication, and don't make major changes in your diet. How it is going to affect diet. There are some diet like green leafy vegetables and all. They have like high content of vitamin K. So don't make like significant changes in your diet suddenly. Yeah, and drink in moderation and avoid binge drinking. That's a very important thing. Sometimes this patient is asking, doctor, I want to go out and have a beer. Can I do it? The thing is, this patient having a bit of mental problem, mental or a learning disability. But these patients who are on warfarin, they can drink, but they can drink in moderation. But we need to tell them, please avoid binge drinking. That is very, very, very important. Let's go to the next station. It's a needle stick injury. We have two stations of needle stick injury. In one, we are talking to the patient. In one, oh, sorry, not the patient. We are talking to the nurse. And in the second one, we are talking to a nanny. Is a child station, we are talking to nanny. In one, we are talking to nurse. So let's see. You are in A&E, nurse colleague pricked herself while taking the blood from a patient to address a concern. That's the thing. Okay, so how we have to approach in these kind of cases if there is any needle stick injury. So this is the thing that you need to ask the patient, like, did you dispose the needle in the sharp spine or not? Usually patient is saying that the nurse is saying, yes, I disposed the needle in the sharp spine. So you did a great job. Appreciate her. Wash the hand under running water with soap. That's a good thing. So you can ask, like, after you had this injury, what did you do? And she's saying, doctor, actually, I washed my hand under running tap water and with the soap. Okay, that's a good thing that you did. Did you inform the senior? Yes, I did. And did you go to occupational health checkup to seek medical advice? The thing is, in these cases, we need to fill incident form. First of all, why we fill incident form? Because we need to be a bit aware about all those things. Because the nurse, she's working in the hospital, yeah, and if she's having an infection, she can spread this infection to other patients as well. So that's why filling the incident form is very, very important. So what happens is, where we fill the incident form, it depends on the timing actually. If it is in the morning time, 9 to 5, they go to occupational health checkup and they will notify there and they will fill the incident form and will get the advices from there. But if it is out of hours, if it is apart from 9 to 5 hours, I mean, if not 9 to 5, then where you will go. And then if it is out of hour, it is usually in A&E. If the patient came to A&E, maybe it's because of out of hours. So these are things that we need to mention. Now, how will you elaborate the incident? Needle stick. So ask these questions. First, when did it happen? Were you gloved or not? Whether the cut was superficial or deep? And what did you do after that? So all those things. And patient is saying, it happened just 1 hour ago, doctor. I was gloved and it was a superficial wound. And after that, what I did is I just washed it under tap water. So appreciate her if she has done any good thing. Okay. The question is, patient is concerned about some infections. So you can ask about the patient as well, because how our nurse colleague will get the infection? She will get the infection from the patient because she was withdrawing the blood from the patient, and that's the time she got the needle stick injury. So ask about the condition of the patient. If patient is a diagnosed case of anything or not. So that's how we will manage this case. So in this station, that nurse colleague is saying, doctor, our patient is a diagnosed case of, or the suspected case of meningitis. She's not saying it's a diagnosed case. It's a what do you say? Sorry, it's a suspected case of meningitis. So how will you manage it? Uh, you can ask one thing: did you take universal precaution before approaching to the patient? That is very, very important. If you have taken universal precaution or not. So if patient was taking universal precaution, then it's unlikely that patient will develop a meningitis. So See, any patient in the hospital, if we are suspecting meningitis, we take universal precaution. You know that. Because we have done meningitis station. Before we approach the patient, we mention that I assume I have taken universal precaution. So same here, if there is a suspicion that the patient might be meningitis, so when the nurse, she approached for taking this blood sample, she must have taken universal precaution. Ask her if she has taken universal precaution or not. So if she says yes, then the chances of getting meningitis are very, very less. First of all, our patient is not a diagnosed case. We are only suspecting. So first of all, we'll see if she's having meningitis or not, and we can also talk to the microbiologist and let's see if there is a need to give you antibiotics or not. So that is what you can say. Yeah. In this patient is concerned about two more things. Patient is concerned about HIV and hepatitis as well. So now in these two things, hepatitis and HIV, you need to do some things. You need to do something like before you give the advices about the medication and all, you need to reassure the patient. First of all, the chances of getting HIV is very, very less. Why? Because for you to get HIV, patient should be infected, and not all the patients who are admitted in the hospital have HIV. So that is one very good argument that you can say. And you told that after you had needle stick injury, you were gloved, yeah, and you washed it under tap water with soap, yeah. So these are the chances which will decrease the infection, the chances of infection, chances of you getting HIV or hepatitis. So first of all, reassure her. This station is actually more about reassurance. It's not about the management of HIV prophylaxis or the hepatitis B prophylaxis. This station is more about reassurance. So what you are supposed to do is you need to reassure the patient. You need to reassure the patient lots. Yeah. And after that, what is the treatment? HIV, we can offer the HIV prophylaxis. So patient has to take two medications actually, and it's for 28 hours, 28 days. So patient has to take the medication for 28 days. Yeah. So it's a two medication. One is like once a day. One is twice per day. This is how patient has to take, but it's for 28 days. But tell the patient like these medication is having a lot of side effects. So once you have started the course, make sure you finish the course. Yeah. And tell the patient for something as well like. About the safe sex, I mean, don't do sex or safe sex in this particular time frame, and don't do any blood transfusion. All those things. Yeah. Hepatitis B, again, reassure the patient. If she is concerned about the hepatitis B, reassure the patient again. Yeah, there's a chances of you getting hepatitis B very, 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 very less because you are because first of all, patient should have hepatitis. Patient isn't. I mean, we are not sure if the patient is having hepatitis or not. And secondly, you were gloved. Uh, you were gloved and you washed the hand under tap water after you had the injury. So chances of you getting hepatitis very, very low. Sometime when you are mentioning about, when you are reassuring her about HIV, patient will say, the nurse will ask you, doctor, so can you do one thing? Can you check the patient for HIV? So what do you think? Can we check the patient for HIV in this case? The answer is without the consent, no. So what you can say the patient that we can check the patient's record if it is mentioned in the record that patient is HIV or not. Yeah, but uh, patient is unconscious because in this case mostly the nurse is saying patient is unconscious. So if patient is unconscious, we'll wait for the time being. Once he will he'll be okay, and only then we can check. We can ask him for HIV, and only then we can check HIV. But otherwise we can't. So sometime you will come across to this question as well for HIV, but it's not like you will be able to check HIV without patient consent. There is a needle stick injury child as well at the same station. I mean, uh, you are in A&E, 3-year-old child was brought to the hospital by the nanny. She had a needle stick injury. Talk to the nanny, take history and address the concern. Child is in the next room and the nurse colleague is looking after the child. So again, the same stuff you need to ask. Same stuff you need to ask. When did it happen? What kind of needle? See, why we are asking what kind of needle? In the previous station, she was telling that I was taking the blood, I was withdrawing the blood. So no need to ask what kind of needle. But in this scenario, you need to ask what kind of needle. Is it was it attached to the syringe or it is without syringe? See, if it was a simple needle, so it doesn't make much difference. But if it's a needle that is attached to the syringe, so it's a bit like risky. Okay, and you need to ask if there was any blood or not, and whether the needle was rusty or not. We didn't asked rusty question in the previous station because patient, where was the patient? Patient was a nurse in the hospital, so there is no chance that the hospital needle is rusty. Yeah, but here you can ask because this child had this needle stick injury while he was playing in the park. While I was playing in the park, so it's always better to ask about this thing whether the needle was rusty or not, and you can ask about how deep was the injury, whether it was superficial or deep, all these things. Yeah, and again, in this station, the patient is already more concerned about the infections. Again, infection. You are talking to nanny actually. You are talking to nanny in this station, and she's a bit worried about the child. So she's worried about again some infection. She's worried about mainly about the tetanus actually. So what do you think? Should we give tetanus or not? And she's worried about hepatitis and HIV as well. The thing is, in the previous station, when you're talking to nurse, we offered her HIV prophylaxis, yeah, because she's working in the hospital environments. That's why. But in this case, actually, there's no need to offer HIV prophylaxis. You just have to reassure. And that's the thing for tetanus. There's a possibility of catching the tetanus bug, especially if the needle is rusty. So actually what we can do is we can give a jab to the patient. One, we give the jab. We usually give tetanus immunization at the age of 2 months, 3 months and 4 months. And we give another 2. We then give one jab before going to school and other one post school. So actually we give 5 times tetanus. One is 2 months, 3 months, 4 months. And then we give roughly at the age of 3 years when child is about to start the school. So this child is actually that we're having is a 3 years old. So we can say at this time what we can do, we can give one tetanus injection, tetanus jab, tetanus immunization. Yeah, and then that's it. And the one we give actually at 16, roughly 16 when they finish their school. Yeah, so in this case, again you need to reassure nanny that you don't have to worry. Chances of getting HIV hepatitis are very low. Yeah, why? Because the chances of getting very low because these bugs, the HIV or hepatitis bugs, they cannot survive outside the human body. And see, in the previous station, when you're talking to the nurse, it was a fresh blood. But in this, it's not. Sometimes she's saying there was no blood, but it is not the fresh injury. If the needle was not fresh. So for getting HIV and hepatitis, they don't survive. These bugs, they don't survive outside the body. So that is a good explanation that you can give, and you can convince the patient. Now we have some station for COPD smoking cessation. All right, so let's read this. You are active medicine. Patient is 65, come for annual checkup. You are diagnosed with COPD and is taking inhalers. And time to time, he has to take antibiotics for his recurrent chest infection. Nurse colleague has examined him, and you need to talk to him, take history, and discuss the plan of treatment. Yeah. So in this case, again, like we do in all the cases, explore COPD, ask past medical history, personal history, and advise accordingly. That's it. There's nothing in this station. What happens is in this station, what you will get history of smoking positive. smoking history is positive, and what we are supposed to do is just need to give advice about the smoking cessation. Yeah, COPD smoking cessation. There's nothing much in this station actually. You will get smoking for sure it is positive, and just advise the patient about the smoking cessation. Like there is a clinic, smoking cessation clinic. You can offer NRT patches, that's nicotine replacement, that is patches or gum, and you can give some medication like Varenicline and bupropion. That's it. Again, there is one more station, smoking cessation. So again, there is nothing there in this station. Let's read the question. You are in Act 2 in medicine. Patient is 50-year-old, presented to the hospital. She was diagnosed with the she was diagnosed with unstable angina, and she was planned to have an angioplasty. Patient had high cholesterol and she is on statin and aspirin. Her condition is controlled. But patient is smoking heavily, 20 cigarettes from last 35 years, and she is not willing to stop. Talk to the patient about the vascular risk and lifestyle modification and smoking cessation. It's typical smoking cessation station. Yeah. So what you are supposed to do is again explore the angina, take past medical history, personal history, and advise accordingly. Again, there is nothing in the station. It's typical smoking cessation. But sometimes what happens? Sometimes patient is ready to listen about the smoking cessation stuff, but sometimes she's a bit annoyed and she's like, doctor, if you're here to talk about smoking, then don't talk to me. That time the station becomes a bit tricky. So take history and all, and later on she will talk about the smoking cessation. But yeah, so what you can do is, she doesn't want to talk about smoking, talk about other things. Like patient is having angina, ask her, do eyes, I would say, do you have any idea why you had this angina? She's like, yeah, there can be many reasons. Yes, but you don't have any medical condition, you have no problem. But sometimes she's saying, doctor, it might be because of stress. Yes, it might be because of stress. What else it can be? Is it smoking, doctor? She might say herself that, is it smoking? So that is the reason, because sometimes she's a bit like, what do you say, a bit a tough patient, I would say. She doesn't want to talk about smoking, but eventually after 4, 5, 6 months, she will talk about smoking. Yeah. There is a next station of respiratory tract infection. It's a straightforward station actually. Let's read the question. You are acting GP. Patient was present to the clinic because of problem in the problem that she had before. Problem she had before. All right. Patient came to the clinic 2 days ago because of runny nose, sore throat, sneezing, and cough. Patient has been seen by the nurse practitioner. Swab was taken. There was no bacterial growth. She was diagnosed with the upper respiratory tract infection. Mild analgesics were prescribed and steam inhalation was advised. Talk to the patient, assess, and address the concern. So simply it's written, swab shows no bacterial growth. So if there is no bacterial growth, it's a viral, then why we need to give antibiotic? There's no need. This is what you need to tell the patient. So initially, elaborate a bit about the flu, because the patient came 2 days ago. Then we answer questions. So now patient came again, so ask about the flu again. How was the flu? How many days? And all those things. Assess the present condition of the patient. Yeah, and ask about the complications. See, this flu and these things can lead to meningitis and all. I know it's very unlikely, but still it can lead to meningitis, my friend. But the thing is, what we need to do is ask about the complication. Any fever, flu-like symptom, maybe patient is having. Ask about rash or neck stiffness or photophobia. All those things. Try to rule out this. Yeah, the meningitis part of it. And then this patient is like, I want antibiotics. So you have to say there is no need to take antibiotics, and you need to explain to the patient that why there is no need for antibiotics, because we have done your culture, and there is no bacterial growth in that. It's totally viral. But she's like, doctor, I'm having this trouble. It's been going on for so many days, and I have to attend the friend's marriage as well. Doctor, please give me antibiotics. So what's your answer? The answer is, there is no need to take antibiotics. And if we give antibiotics when there is no need, for example, now you might end up having resistance in the future. So maybe in the future, when you really need antibiotics, that antibiotics will not work. That's why we are not giving you antibiotics, because there is no need. That's it. Yeah. So convince her for that. And the warning sign, once you finish the station, you can give some warning sign, like if you develop headache, rash, ear pain, discharge, testicular sputum, and if your symptom doesn't subside within 2 weeks, to come back. Sorry. Skin lesion. We have 3 stations of skin lesion. Let's cover all 3 stations. Almost a similar one. You are in surgery clinic. Patient age is 32. Sorry. So patient age is 32. Presented to the hospital. The presence of a lesion on her right shoulder. She has a letter from her GP. Patient has a letter from the GP. The letter states that patient has some concern about the lesion and wants to remove it from the shoulder. Talk to the patient, take history, assess and discuss the plan of management. And discuss about the daycare procedure, daycare surgery, and take relevant consent for the surgical procedure if needed. Consent form is not available in the cubicle. The thing is, consent is like it's a verbal consent. If you feel like that if you feel like there is a need of surgery, then you will take verbal consent. It's not about the consent station. Yeah. So what you have to do in this case is elaborate that skin lesion. So we have quite a few stations of skin lesion, 3 stations actually. So in all skin lesion station, what you need to do is you need to ask these questions. What's the size of the lesion? What's the shape? What is the color? If there's an itching, any discharge, or any ulceration, or ask any change in the size, shape, color. Yeah, first ask what is the size, shape, color, then any change in the size, shape, color, and if there's an itching, discharge, or any ulceration. So this is what you need to ask. Skin lesion, it can be cancer as well. Just to be on the safe side, ask this weight loss, appetite, and anemia symptom. Yeah, and then take the past medical history and personal history. Yeah, and now the question comes: we have a 3 lesion. Yeah, we have 3 lesion. Let me show you the picture of the lesion. Then we will explain it. This is the first one. It is a mole. It is a benign lesion. No need to worry actually. And this is the other one. This is actually melanoma. It's a skin cancer. And there is another one. Actually, it's non-melanoma. It can be BCC. It can be SCC. It can be basal cell carcinoma. It can be squamous cell carcinoma. But you can say it's non-melanoma. Or simply it's a skin cancer. Don't take it. Don't have to say what it is. It's a skin cancer. And skin cancer is a thing that patient can understand. So I have to talk in the language where patient can understand. So the thing is how we have to start this station. We have elaborated everything. We have elaborated about the size, shape, color, itching, everything. We asked about weight loss, loss of appetite, anemia symptoms. And after that, we have taken past medical history and personal history. Now, if it is a mole, for example, if it is this kind of picture, if this is the picture in the exam, then you have to ask one question to the patient that why you want to remove it. Is it uncomfortable? What is the thing? Because mole is a benign stuff. It's not changing in size, shape, color, no itching, no nothing. So why you want to remove it? Because you know why we are asking? Because cosmetic surgeries are not funded by NHS. If this lesion is giving some trouble to the patient, if patient is feeling uncomfortable because of that, even if it's affecting her confidence, then we will remove it. And it will be removed under NHS funding, no problem. But if this lesion is not making her uncomfortable, it's not even affecting her confidence, and she wants to remove it because it doesn't look good, only for the cosmetic purpose, then NHS will not cover this. All right, and the treatment of this thing is safe excision, freezing with the liquid nitrogen, laser removal, and all these things can be done as a daycare surgery. Yeah. But if you have this one, or if you have this one, then what's the case? In this case, you don't have to ask the patient whether you want to remove it or not, because you have to remove it, because it is cancer. It is skin cancer. So how will you deal with this kind of station? If you have this station, so what you need to do is, you need to mention about this. You need to mention about excisional biopsy, and you need to mention about 2 weeks urgent referral and local excision. As we have done already, any cancer, it's 2 weeks urgent referral. So first is excisional biopsy. We will check if it is cancerous. We'll do local excision, and it's 2 weeks urgent referral. Yeah, all the cancer, 2 weeks urgent referral. Gluten celiac disease. This counseling station actually. Let's just it's a pretty straightforward and simple question. Just a second. It's almost done. Like we're left with 5-6 station. Hmm. Just a second. Okay, so celiac disease. Let's read the question here. The question is: you are inactive in the medicine. Patient is 47, came to the hospital because of tiredness. All right, she was prescribed iron tablets by a GP for iron deficiency anemia, and the patient underwent some tests and found to have tissue transglutaminase 2, that is TTGA2, that is positive, and it is for celiac disease. So it's mentioned patient celiac disease antibody is positive, and patient was planned to have an endoscopy and duodenal biopsy. Talk to the patient, assess and address the concern. The thing is, in this station, we have written all the history questions in the station and all, but this patient usually tells you all the history in one go. The station is not about the history. It's not about the celiac disease. It's a diagnosed stuff. It's already diagnosed. This station is about mm, 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 this station is actually about what do you say? The convincing the patient for endoscopy. The thing is, patient is saying, I'm already diagnosed with the celiac disease, so why you want to do endoscopy and duodenal biopsy? You already told my GP told me that this is a celiac disease. Why? So that's a valid concern, isn't it? So the reason that why we have to do endoscopy is to confirm the diagnosis, because patient is having tiredness, and the patient is sometimes concerned about the cancer as well. Doctor, is it cancer? Because cancer also patient have tiredness. Yeah. So here also patient is having tiredness and diarrhea and all a bit similar symptoms like cancer as well. But tell the patient like, yes, some of the tests came back positive, but to confirm it, if it is celiac disease or not, then we need to do endoscopy and we need to do the biopsy. Patient like, no, it's uncomfortable. Yes, it might be a bit uncomfortable, but we can give you some medication to relieve your discomfort. This is what you can say. And you need to convince this patient for the endoscopy. Just one thing that you need to take care in your mind is uh, this when we are doing endoscopy or the biopsy, patient should be on gluten diet. Patient should not be on gluten-free diet. Patient should be on gluten diet. Only then you can do this test, the endoscopy and the biopsy. Otherwise, if you will keep the patient on gluten-free diet and then you will take the sample, then you will take the duodenal biopsy, the results will be faulty. So there's no point of taking the sample that time. Yeah. So that is the thing that you need to keep in mind. All right. So that's the case. So take a bit of history, ask about what was the symptom, and our patient is usually telling about the diarrhea and telling about the tiredness. So elaborate those things, but usually patient will tell you everything in one go because it's not the diagnosis case, it's the counseling station. And need to counsel the patient of endoscopy. Why we are doing endoscopy? To confirm that. Post-op hemiarthroplasty. Yeah. So let's read the question. You are after an ortho and the patient is 78 years old, presented to the hospital due to the fracture of neck of femur. She has been planned to have a hemiarthroplasty. Talk to the patient, discuss about post-operative management and the complications. Yeah. Discuss about the management once patient has got discharged and address a concern. Anesthetist has explained the pain management and the consultant has explained the procedure. So it's very clearly mentioned in the station that the procedure has been explained to the patient and the pain management has already been explained to the patient. Patient has some concern and patient has some concern about when we will discharge the patient. So when we discharge the patient, we'll shift the patient to home. So she has good concern. So what we have to do in this case, as we do in all the stations, like present situation, how are you feeling now? Are you fine? Any problem? So patient has got some concern. First concern is when I be able to walk. So when the patient will be able to walk. Actually, in these kind of patients, like hemiarthroplasty stations, we try to mobilize our patient as soon as possible after the surgery. So when I'll be able to walk, we'll try to mobilize you as soon as after the surgery, because we don't want you to have the complication. And she will ask, what are the complications? Some complications are like pain. Pain is already been managed by the anesthetist, so don't mention that much. Infection, maybe, or maybe the damage to surrounding structures. So these things can be managed. And one of the most important complication of this case is DVT. Actually, she's a lot more worried about DVT, deep vein thrombosis. Yeah, she's worried about DVT, deep vein thrombosis. So you need to mention that thing to her. Like, this is one of the complications, but that's why we are trying to mobilize you as soon as possible after the surgery to prevent a complication, this DVT, from happening. Yeah, and that's it. And we'll take a bit of past medical history. So this is the addressing the concern. Now there is one more thing in this station is, how will I get around my home and all those things. So what you need to do is you need to mention about occupational therapist. So what's the work of occupational therapist? So anything at home is done by these occupational therapists. So what they will do, they will make sure everything is at one floor. For example, patient got new hips now, and if all the facilities like the bathroom, the kitchen, the living room are not at one floor, that will be trouble for the patient. So we will arrange something for that. Maybe it's not advisable in the beginning that you are climbing the stairs. So what can be done in this case? So maybe we will arrange everything on one floor, or we can arrange lift, or we can arrange a ramp and electric chair for the patient. So this is the work done by the occupational therapist. So whatever is the patient's concern, we can manage that. And finish the station and mention about the warning sign of DVT. If you develop any redness, hotness in your calf muscles, or if you have a breathing problem, because DVT can lead to PE, so we can give the warning sign for that as well. Yeah, so that will be the thing that you need to mention in this station. So yeah, it's a pre-op assessment. Pre-op assessment is ankle pin removal station. It's a pre-op assessment like PAC, pre-anesthetic checkup. So those who are anesthetists, it's very easy for them. Yeah, pre-op assessment. So let's see the question first. What is the question here? The question says you are in surgery department. The patient is 48, presented to the hospital with the for his pre-operative assessment. He has been arranged to have an operation under general anesthesia for the removal of the screw in his ankle. His operation will be done in 2 weeks' time. He had an ankle fracture 12 months ago and underwent a surgery because of it. Please talk to the patient, assess his pre-operation fitness for the day care surgery, and address his concern. So patient actually had a surgery one back, and there was a pin inserted in his ankle. Now he's take past medical history of the patient. If patient has been diagnosed with any past medical condition or not, and usually in this case, the patient is giving a past medical history of diabetes. So you will elaborate this diabetes. So how will we elaborate the diabetes? You can elaborate the diabetes by asking like for how long you are having this diabetes, what you are taking for this diabetes. Usually this patient is taking the short-acting insulin, and before going to bed, he's taking long-acting, that is Lantus. So I'm taking Atropid doctor 3 times a day, and I'm taking Lantus before going to bed. Yeah, so you have elaborated the past medical history, personal history, everything you have to elaborate. So make sure when you're asking about the history, after that you need to examine. Examination, you need to mention about everything. Yeah, BMI, heart, lung, tummy, MRSS screening, because every time we do MRSS screening, so say we will be doing MRSS screening. And airway bend neck movement. See, in PAC, definitely we have to check this neck. If it's very short neck or it's okay. I mean the airway, because we may have to do this, what do you say, the tube we have to insert. So all those things we have to make sure there should not be any problem. Ask about any other medical condition like related to the chest, like lungs, very important lungs, because if patient is having asthma and all, it's difficult. Maybe high risk consent you have to take. Yeah, so all these things are really really important. And PAC we do history, we did examination, we did. What else we do in PAC? We do investigations as well. Yeah, so we'll be doing all the investigation like blood investigation, urine investigation, and ECG. Yeah, and you must be thinking X-ray, chest X-ray. Do we do chest X-ray? Usually not. We usually don't do ECG even in this country. I mean, no, it's just a bit weird. We don't do. But if the age of the patient is more than 40, 45, we go for ECG. But chest X-ray we usually don't do unless patient is having any medical condition for the chest. Then we can go for chest X-ray. Otherwise, we don't expose the patient to radiations unnecessarily. Yeah, otherwise the blood, urine, and ECG, that's more than enough for the patient. All right. And then what is the advice that you need to give that NPO, like when you are coming for the surgery, do not eat anything. I mean, the patient is supposed to have surgery in the morning. So tell the patient, eat as you like in the evening time, as you usually eat. Take your insulin as usual in the night. After that, don't eat anything till morning and don't take your morning insulin dose. Come to the hospital. We'll manage after that. That is the advice you need to give to this patient. That's it. And one very, very, very important thing, that is this one. Don't send him home if he's living alone. See, if patient is having diabetes and all these kind of patient, I know it's a daycare surgery. It's mentioned it's a daycare surgery. But if patient is living alone, it is not good that if you will send this patient home. Why? Why it's not good? Patient can have some problem actually. So it's advisable for the patient to have someone. So you can ask it in the social history whom you live with. This patient is very smart. Will tell you, doctor, I'm leaving alone. So are you going to send this patient home or not? It's not a risky thing. But this patient is saying, doctor, I can ask, and he can come and he can stay with me. Then that's fine. That's acceptable. But it's advisable not to keep the patient alone at home if he's having these kind of problems. Herniorrhaphy. Herniorrhaphy. It's wrong. Herniorrhaphy. You have to, in surgery, patient is a 40-year-old, has been planned to have a right inguinal hernia repair. Anesthetists have done the assessment, and your nurse colleague measured the blood pressure, which is a bit high, 150/88. Explain the procedure, address the concern, and consultant will come later to take consent. In this station, what they have already done, they have done the assessment. The pre-operative assessment has been done. You just have to explain the procedure. Actually, in the script, you'll see it's a bit lengthy. Why? Because we have done the pre-op assessment as well. But if this line there that anesthetists have done the assessment, then you can skip the part of assessment. What we are supposed to do? We are supposed to do only the explanation of the procedure, and we need to address the concern. Yeah. So now, if a patient's blood pressure is high, so can we do the surgery? Yeah, I mean, we can do the surgery. But this hernia repair can be done in two ways. One is open surgery. One is what do you say? And under this, one is open surgery, one is keyhole, that is laparoscopically. For laparoscopic, what we need to give the general anesthesia to the patient. Yeah, we need to give general anesthesia to the patient when we are doing keyhole. But open surgery for hernia can be done in spinal as well. For spinal anesthesia, we don't need much of what do you say? We don't need that much the level of what to say? The level of fitness, I mean, for spinal anesthesia. But for general anesthesia, patient should be fully stable. Yeah. So that's the thing. So in this case, the blood pressure is high. So you will give both the options to the patient. That we can go with the open surgery and the closed surgery. That's true. I mean, not closed. One is open, one is laparoscopic. But if this hernia is causing a lot of problem to the patient, so ask if the hernia is obstructed or not. That's the main thing. If patient is having any obstruction, patient is having any constipation, or if it is very painful, so it means it is obstructed. In that case, you need to do the surgery now. Doesn't matter what's the blood pressure. So you will just do the surgery in the spinal. And because we don't need much of the fitness for the spinal, but you can do only what you can do is open surgery. So that's the thing. So you can give option to the patient. So in this station, how will we go? We assess the patient PMH in person. So same thing as we do in all the station. Now give option to the patient in anesthesia or spinal anesthesia or general anesthesia. If you want surgery, the laparoscopic one, it will be in general anesthesia and you need to wait for that. But if it is an emergency, we can go now. That will be open surgery under spinal anesthesia. That is the thing. And you will explain both the surgeries, how it is done openly and how it is done under the spinal anesthesia. As simple as that. There is no problem in it. And finally, you can explain the keyhole surgery and how it's done. Like we will make a hole just near the umbilicus. We will put our scope in that. Then we will insert some air, and we'll be able to visualize all the organs inside. So we'll make two small holes more, and we will insert our instrument through them. We'll be inserting the camera as well, so we'll be able to visualize the structure inside it, and then we can do the surgery. So this is how you can explain the spinal and the general anesthesia. I mentioned about the truss as well. So that's the thing. But make sure this is an important thing in this station is local or general anesthesia. General anesthesia, we can do keyhole surgery as well. Local or spinal, only the open surgery, not the spinal. So this is actually, you can explain the surgery is actually like the surgery under local anesthesia. We inject into your spine. You will be awake during the procedure, but the area being operated on will be numbed, so you will not experience any pain. And once the anesthetic has shown the effect, the surgeon make an incision over the hernia. The surgeon then place the lump or fatty tissue or loop of bowel back into the tummy, and then we place a mesh. That's it. We place a mesh on the tummy wall over the hole at the weak spot where the hernia came through to strengthen it. Yeah, and when the hernia repair is complete, your skin will be sealed with the stitches and it will dissolve in few next days after the operation. So this is how you can explain it. It's written in your booklet, so you can just read it. But we need to give two options. One is open, one is laparoscopic. Yeah. How long will the surgery last? For how long I have to stay in the hospital and the complication of the surgery. So these are the questions that patient can ask. So that you can answer. It's an easy one. And there are some other questions that patient can ask. How should I take care of my wound? Will I be able to take a shower? When I can dry? When I can resume my sexual activity? When I can go to my work? How long the surgery lasts? It will take a couple of hours. How long I have to stay in the hospital? It for like a couple of days, and once you make sure everything is fine, your still will send you. Complication of the surgery, every surgery has got complication, like pain, like infection, like bleeding, or maybe damage to a surrounding structure. But we will take care of all those things. How should I take care of my wound? So make sure in the beginning, like the water, you have to take care from the water. That's the mainly. Will I be able to take shower? Yes, after a few days you can. You will be able to take shower, but in the beginning, just cover this wound and don't wet it. When can I do it? When you are able to push the emergency brake, when you're able to make the emergency brake, you can drive. So it's roughly take 4 weeks. When I can resume my sexual activity, again 4 weeks maybe, but when you are able to do it without feeling breathless. When I can go to my work, when I can go to my work, so ask what work you do. So it depends what work this patient is doing. If he's doing heavy work or a simple office work, it depends on that. Yeah. The next station is again similar kind of station actually. It's a dermoid cyst station. Patient is your absent surgery. Patient age is 24% of the hospital with abdominal pain. Ultrasound has been done and it shows dermoid cyst in the right ovary. Consultant has decided to do open ovarian cystectomy with an incision of 8.5 centimeter. Consultant has decided to keep the patient in the hospital after surgery for 2 days. Talk to the patient and address the concerns. Talk to the patient and address the concerns. It's a very straightforward. Everything is given in the question, so there is no point of putting keyhole surgeries and all, because it's decided that open surgery. Usually, when we do open surgery for ovarian one, it's usually what do you say? It's a bikini line incision. It's a bikini line. So incision will be made at the bikini line. Yeah. So in this case, what you need to do, as we did in the previous, like assess the patient condition, PMH, past medical history, and personal history, as we did in all the stations, and then we need to explain the open surgery. Open surgery is in this we will put you to sleep, and incision will be made on your bikini line. Actually, it's a incision or bikini line incision. Then we will remove your cyst, and in the most of the cases, we remove only the cyst. But in some cases, what we have to do is we may have to remove the whole ovary as well. So the thing is, it's better to tell the patient beforehand. When you're doing surgery, you cannot ask the patient. Yeah. So in this kind of surgery, you need to explain all these things before you do the surgery. That usually will take out only the cyst, but in some cases, we may have to remove the whole ovary. So the consent that you will take for this thing as well. So it's better you will explain all these things. Yeah. And how long the surgery lasts? What's the size of the scar? You have the answer. Size of scar is 8.5 centimeters written in the question. Will I be able to become pregnant? So what do you think? Yeah, I mean, we are removing only the cyst, so you can become pregnant. But in case if you have to remove the ovary, still you have two ovaries, so still you can become pregnant. Yeah, the last station is breast pain management. Let's do this as well. Oh, God. The question is, you are actually in the medical unit. Patient is 60-year-old, has been referred from the oncology to acute medical unit for pain management. She has been diagnosed with the breast cancer 5 years ago, and now she presented with the back pain. So what do you mean by back pain? So it means it's metastasized to the back. Talk to the patient, outline a treatment plan, and address the concern. Yeah. So what we need to do in this case, before we discuss it, let's see this, the pain ladder. See, in all the stuff, what we do is the first thing that we give is non-opioid. Non-opioid means paracetamol or NSAIDs. So these things you can see here first. The non-opioid drugs, mainly the paracetamol or NSAIDs, or the combination of these two. Yeah, paracetamol, NSAIDs, and the COX-2 inhibitors like aspirin. So this is the first thing that we give to the patient. If pain is not relieved, we go up. We go up the ladder. That is weak opioid. That's the second thing we give. Yeah, weak opioid, usually codeine or tramadol. So we usually give codeine, but weak opioid added, not substituted. What does it mean? It means we will not stop paracetamol. We usually add codeine. So if after giving paracetamol, patient is in pain, we go to next ladder and we will give paracetamol plus codeine, not only codeine plus codeine. Yeah, so usually it comes with a combination name as cocodamol. Cocodamol is codeine plus paracetamol. And after that, we can go again to the lab. This is the top one. It is a strong opioid, which is morphine, actually, morphine. So again, if pain is not getting relieved with cocodamol, we'll go for morphine. Yeah, this is the usual thing that we do. So come here in this non-opioid plus minus adjuvant. What do we understand by adjuvant? Non-opioid, we understood. It's paracetamol, it's NSAID. What is adjuvant? The adjuvant are not the painkillers, but they help in pain relief. What do you mean? The meaning is, for example, if you're having a neuropathic pain, give paracetamol, give codeine, give morphine, it's not going to help. But if you give some adjuvant, for example, if you give gabapentin, pregabalin, that will be helpful. Yeah, that is an adjuvant. For breast cancer, chemotherapy, radiotherapy, that is an adjuvant. We do give chemotherapy, radiotherapy for pain relief. That is an adjuvant. Sometimes a patient is having osteoporosis, osteoarthritis, painkiller not that helpful, but when we give this phosphonates, we give steroid injections, that is helpful, that is an adjuvant. So non-opioid plus minus adjuvant, just see if you can give any adjuvant or not. Yeah. So first of all, what we give non-opioid, that is paracetamol, and plus minus adjuvant. So if patient is still in pain, first take history. Ask the patient if patient is taking that paracetamol on time or not. If patient is compliant or not. See, if patient is not compliant to paracetamol, there is no point of adding any other medication. It's useless. So first make sure patient is on highest dose of paracetamol. If still in pain, then only we will go for next ladder, which is codeine plus paracetamol. That is cocodamol. Yeah. So that's the thing that you need to make sure. So opioid for mild to moderate pain. Yeah. So first paracetamol plus minus adjuvant. When we have checked the compliance, and if the compliance is there, we'll move to the next ladder, which is opioid, weak opioid, that is codeine, plus non-opioid, which is paracetamol, and plus minus adjuvant. Adjuvant can be anything like, yeah. If still in pain, we will go for opioid for severe pain, which is morphine, plus minus non-opioid, plus minus adjuvant. So this is how we go in this ladder. Yeah. So actually, with the help of this pain ladder, you can solve all the questions. Doesn't matter only this station, you can solve any station. So if you get a new station also for the pain stuff, you know how to tackle it. Yeah. So morphine. Just a second. Just a second. Yeah. So after you have given the morphine and all, sometimes patient will say, doctor, I have a lot of problem with the morphine because morphine is not a drug that you can easily manage. There are lots of side effects of morphine. For example, constipation, like nausea, vomiting, feeling sleepy, tired, dizzy, shallow breathing, lots of side effects. So if page first is paracetamol, then we go ahead cocodamol, then we go for morphine. Patient develops side effect of morphine now. Patient is saying, doctor, I'm having severe nausea, severe vomiting. So now what you are going to do? In that case, are you going to change morphine or have some other option? The thing is, in that case, what you will do is, uh, instead of changing the route of the morphine, what we will do is, we will tackle the side effect. Yeah. So if patient developed any side effect because of morphine, instead of changing the route of medication, we will tackle those side effects. If patient is saying, I'm having nausea, I'm having vomiting, don't change the route of the medication straight away. Tackle the side effect. So how you can manage nausea, vomiting, and constipation? So nausea, vomiting, stick with the simple food. Don't eat spicy food. Don't eat creamy food. Don't eat fried food. Include more of fiber stuff in your diet. Drink plenty of water. This is how you can manage nausea, vomiting, and constipation. But don't change the route of morphine. Yeah, but if you are unable, you have done your best, but still patient is having nausea, vomiting, and constipation, then what you can do? Then there are lots of things that you can do for the patient. We can actually change the route of morphine. We can give this as a subcut route. We can give diamorphine, which is given subcutaneously by a syringe driver. You can give, but there is some problem with the syringe driver as well. What's the problem with the syringe driver? Patient should be at home throughout day night, because it's a continuous infusion that we have to give with the syringe driver, and the route is different. So that is again a problem, isn't it? But that is the option that in the end we will give. If we are unable to manage the side effect, then you can give this a syringe driver. Yeah. And there is another option, which is fentanyl patch. If this patient is telling you, doctor, I have to be mobilized, I have to go to friend's wedding, I have to be mobilized, so in that case, instead of offering syringe driver, we can give fentanyl patch. So fentanyl patch, what's the good thing about fentanyl patch? First of all, you can be mobile. We can give fentanyl patch if we have given full dose of morphine, still patient is in pain, we can give fentanyl patch. If patient wants to be mobile, we can give fentanyl patch.
if patient GFR is low, if patient GFR is less than 30, we can give fentanyl patch. So there are three indications we usually give fentanyl patch. One thing about fentanyl patch is it works for 72 hours. So once you have started, it will work. It takes 24 hours, 12 to 24 hours to show its effect. So you have put fentanyl patch maybe here. For initial 12 to 24 hours, it will not show its effect. So what you need to do is you need to supplement with any other painkiller in the beginning, in the first 12 to 24 hours. But it will work for 72 hours. So once the 72 hours finished, so make sure don't give any painkiller, because this fentanyl patch will work for more 72 hours. I mean, the initial 24 hours, it's not working, but it will work beyond that. After 72 hours, it will work for that 24 hours. I mean, in total, it's going to work for 72 hours, but initial 24 hours, it will not work. That's the thing. So in the end, don't give any painkiller. Otherwise, we can give overdose to the patient. So once patients start feeling pain, only then we will give painkiller. Otherwise, we will not give. So this is something about the fentanyl patch. Syringe driver fentanyl patch. There is one more thing that we have. If you have anything like PCA, patient controlled analgesia, that is we give after surgery. So patient had any surgery, any hysterectomy or any surgery like appendicitis, post appendectomy, open surgery, we usually give one more thing, that is PCA pump, that is patient controlled analgesia. So that's the thing. So usually we start with the paracetamol, we give codeine, codamol, and then morphine and like that. But there are some exceptions, like the post-op cases, we start with the maximum stuff. We start with the maximum stuff. Maximum stuff means with the PCA, patient-controlled analgesia. So that is what we start with, and then we slowly taper it down. So that's the only exception usually, but usually we start with the paracetamol. This is how we go up. So for in this station, again, you will elaborate the pain, you will take past medical history, you will take personal history, and you will see what our patient has already received. This patient is taking paracetamol, patient has tried bisphosphonates, patient has already tried radiochemotherapy, doesn't help. Now this patient wants to know something more about the painkiller. She is already taking paracetamol, she is taking the maximum dose. So what you can offer cocodamol. And after cocodamol, we can offer morphine as well. So this is what you need to ask. And if she asks more side effects, you can explain the side effects also. Sometimes patient is asking one question, is morphine addictive? So what do you think? Is it addictive or not? The thing is, why you are taking morphine, that is important. If you are taking morphine for the psychological purpose, then it is addictive. But if you are taking it for pain as a painkiller, then it's not addictive. So this is the explanation that you can give it to the patient. Yeah, and if she's asking what other options, you have the options of fentanyl patch and syringe driver. That's it. So that's the stuff. Yeah. So these are the things that you need to do. All right. So that is counseling. So today we discussed the medicine part, we discussed surgery, and we discussed counseling. Yeah.